We're going to turn our attention here to the combined immunodeficiencies, and even though these are combined immunodeficiencies, meaning that they affect both B cell function and T cell function, primarily these look just like the T cell immunodeficiencies because the infections that you get from cell-mediated immunodeficiencies are much more prominent, much more severe, and so that's generally how they're going to look. So here we are in our process of talking about immunodeficiencies. So we're going to talk about a few of them. So here's our first vignette. A 6-week-old baby boy presents to your clinic with his parents who complain of watery stools over the past 2 days. He was born at 38 weeks gestation via uncomplicated spontaneous vaginal delivery and weighing 7 pounds 2 ounces, which puts him roughly in the 47th percentile. His birth history is notable only for mild dermatitis, which resolved without treatment. Family history includes a maternal uncle who died at 4 months of age from meningitis. Baby presently weighs 7 pounds 10 ounces, which puts him in the 2nd percentile for his age. Vitals are 65/35, heart rate 160, respiration is 36, temperature 100.4 degrees. Exam is significant for mild thrush, evident dehydration, scattered rhonchi, and mild abdominal distension. Faces are grossly normal. There is no lymphadenopathy. Chest x-ray is ordered and reveals bilateral perihilar infiltrates. There is no discernible thymic shadow, and electrolytes are within normal limits. So I apologize in advance. I'm kind of getting over a cold here, so my voice sounds a little off. Okay, so this is obviously a child that is ill and has been ill often. So we note, first of all, that he's got watery stools over the past 2 days. That's never normal. So we think of some kind of diarrhea. In most children, we would think rotavirus, #1 cause of diarrhea in pediatrics. However, this child has got something much more problematic going on. First of all, he was born normal, 7 pounds 2 ounces, really nothing problematic other than a mild dermatitis, which resolved without treatment, which we really don't think a whole lot of, at least prima facie. But now he weighs 7 pounds 10 ounces, and that is way low. And all you need to do is chart his growth. He started out at the 47th percentile, and now 6 weeks later, he's only at the 2nd percentile. We would expect him to be, at least 8-9 pounds for his age right now. What else do we notice? Well, in his family history, there is a maternal uncle who died at 4 months of age. Now, possibly normal. I mean, it's hard to say, but given the fact that this child is clearly suffering from an infection and clearly is failure to thrive, we want to know about family history of infections, and indeed there's a maternal uncle who died 4 months of age from meningitis, and these days children don't die of meningitis that often. Now when we turn to physical exam, we note that his blood pressure is 65/30. That is low, so he is either dehydrated or septic or both. Normal blood pressure for a child this age would be systolic anywhere between 70 and 90, diastolic anywhere between 30 and 60. And normal heart rate would be about 100 to 180, which he's kind of in that area. But he's also running a fever too. So he's either septic or he's dehydrated, probably dehydrated more so, but we can't really tell. Then when we turn to the physical exam, we note mild thrush, which is unusual, and then evident dehydration. And then we also notice that he's got scattered rhonchi. And when we do a chest x-ray, we note perihilar infiltrates. And that is an unusual way for pneumonia to show up. Based on, and then no discernible thymic shadow, and that's another red flag. Now, if you watched my last lecture, I told you that there are a lot of children that you don't see their thymic shadow, and that is perfectly normal. Not seeing a thymic shadow is not an indicator for anything nefarious. However, when you don't see a thymic shadow in the presence of a child who has got infections, repeated infections, or severe infections, or mucocutaneous candidiasis, we are thinking something probably along the lines of a primary immunodeficiency. And indeed, that is the most likely diagnosis here. So we see acute diarrhea, probably viral, but we don't know. We need to get a stool culture. Failure to thrive, certainly, and then mucocutaneous candidiasis in the form of thrush. And then this pneumonia, this scattered rhonchi, and then the perihilar infiltrates in the setting of a child that's probably got primary immunodeficiency is likely pneumocystis jirovecii pneumonia. And this is all probably in the setting of severe combined immunodeficiency. The fact that there's pneumocystis jirovecii pneumonia, likely. The fact that there's severe failure to thrive, the fact that there's thrush, and the fact that he's got this severe dehydrating diarrhea all point to a cell-mediated immunodeficiency. Remember that if this was a B-cell immunodeficiency, this was something like Bruton's agammaglobulinemia, for instance, we would only expect to see sinopulmonary infections primarily. Maybe you get a diarrhea from that, but you certainly we would expect sinusitis, maybe strep pneumonia, but there's something, there's much more going on here. There's the thrush, and there's some kind of irregular pneumonia. And then you add to that the fact that there's a maternal uncle, which we think X-linked when we're thinking male relatives on mom's side. This is probably severe combined immunodeficiency, but we would have to run more tests to find out. So severe combined immunodeficiency is a life-threatening genetic condition resulting in a severe deficiency of T cells and proper B cell function. So there's going to be a deficiency of T cells. There may be a deficiency of B cells, but because we have a deficiency of T cells, non-functioning T cells, our B cell function is going to be disturbed. Because remember, you need CD4 cells, you need proper function of T cells in order to generate class switching, which we need for proper immunoglobulin levels. And then there can also be an NK cell deficiency. It really depends on the type of severe combined immunodeficiency. There are a lot of them. There's I think there are at least 12 or 15 severe combined immunodeficiencies. However, the most common is X-linked, and so we see this primarily in boys, but there are autosomal recessive variants that we can see in girls as well. But the most common severe combined immunodeficiency is the X-linked severe combined immunodeficiency. So severe combined immunodeficiency presents with severe or unusual infections, and it generally presents prior to 2 months of age. There will be infectious processes going on before 2 months of age. Either this can present with an infection, as it did in this case, or it can present as failure to thrive, just picked up on regular examination, 1 month well-child visit, 2 month well-child visit. Usually the infection that this presents with will be persistent diarrhea. It can also be pneumonia. It can also be acute otitis media, which we would also see in the B-cell disorders, or it could also be candidiasis. And in this child, we see persistent diarrhea, we see pneumonia, and we see candidiasis. So the candidiasis we would only see in the T-cell disorders because you do not need immunoglobulin to fight candidiasis. So you need your T cells for that. Presentation, so the infection profile here is going to be pretty much anything. Anything you can get out in the environment, you're going to be at higher risk with combined immunodeficiency. So viruses, you can get RSV, enterovirus. So with the enterovirus, remember, just like with Bruton's, you can get meningitis and encephalitis from the enterovirus, which we would not expect in an otherwise healthy child. You can get rotavirus, which can cause diarrhea. That could easily be the cause here, but it could also be something else. Parainfluenza virus, CMV, VZV, Epstein-Barr virus, herpes simplex virus, and human herpes virus 8, which remember is behind Kaposi sarcoma. Fungal infections include Candida, it can be MCC, or it can be disseminated. Cryptococcus, Aspergillus, bacteria, Pneumocystis jirovecii, of course, the opportunistic pathogen we're always worried about when there's a T-cell immunodeficiency. If you ever see Pneumocystis jirovecii pneumonia in a child, you should be immediately thinking of a T-cell immunodeficiency. Staph aureus, pneumococci, which of course can also cause pneumonia, H. influenza, Neisseria meningitidis, Pseudomonas, Listeria, and then parasitic infections, including Giardia, Toxoplasma, and Cryptosporidium. Cryptosporidium can also cause diarrhea as well. Okay, so what are the causes of severe combined immunodeficiency? Like I said, there are a lot. However, the most common causes tend to happen pretty early on in the development of T cells. So remember, we start with a lymphoid progenitor. That will ultimately go on to a T cell progenitor. I can't remember, I think it's a pre-T cell. Or pro T cell, and then from there, then you develop your T cell receptor, which points a pre T cell, and then from there, the T cell receptor matures, and you go on to either be a CD4 or a CD8 cell, and there'll be continued maturation after that. So where we see the block or the pathology in the most common types of severe combined immunodeficiency is going to be in that progenitor to pro T cell stage. And the three most common causes of severe combined immunodeficiency are the X-linked severe combined immunodeficiency, the ADA deficiency, and then the IL-7R alpha deficiency. So ADA is just an enzyme that's responsible for metabolizing purines, and IL-7R alpha deficiency is a deficiency of a specific receptor, a receptor for IL-7, which is responsible for T cell receptor rearrangement, that whole VDR rearrangement process, and then VDJ rearrangement, and then it's also an anti-apoptotic signal transducer. So what that means is that receptor tells you to not go into apoptosis. And so if you have a deficiency, you're going to have apoptosis, namely apoptosis of the T cells. So you can see how all of these are going to result in issues with the T cells. So this is, do not memorize this, please. This is just a list of all the various causes of severe combined immunodeficiency, and this actually isn't even all of them. But what I want you to get out of this is the top three, and then a couple other things. So the X-linked severe combined immunodeficiency is also known as the common gamma C immunodeficiency, and this affects T cells and to a lesser extent the natural killer cells. It's inherited as an X-linked recessive condition. The ADA deficiency is going to affect all of your cell lines, all of your lymphoid lines. So the reason for this is because ADA is expressed in all of these cells. And remember what I said, ADA is responsible for purine metabolism. And so if you cannot metabolize those purines, those metabolites are going to build up, and those metabolites are actually cytotoxic. And so it's going to affect all three of these lines. Then the IL-7R alpha deficiency, IL-7 receptor is only expressed in the T cells. So this is only going to affect the T cell line. JAK3 is a protein that it's an enzyme that is expressed in the T cells, and it is responsible for the JAK-STAT pathway, which we see in T cells. And what you can get from this is that JAK3 transduces a signal from that common gamma part of the receptor, the T cell receptor, and so it looks just like X-linked severe combined immunodeficiency. and that's just because it's just one step down in that cascade. Omen syndrome is an unusual disorder. It's not very common. We see it primarily in two populations: Native Americans, namely Navajos, and we also see it in Mennonites. Okay, so really kind of random, but it is composed of two different. It can be one of two deficiencies. It can be a deficiency of RAG1 or RAG2, or it can be a deficiency of a protein called artemis. And these proteins are involved in that VDJ recombination process where you're developing novel T-cell receptors. And so if you have a deficiency there, you're going to have a hard time developing proper T cells. And really the T cells that you do develop are primarily going to be autoactive. So you'll have T cell infiltration of the skin, which can cause an exfoliative dermatitis. You can get hepatosplenomegaly from T cell infiltration of the liver and spleen. You can get an intractable diarrhea from T cell infiltration of the intestines. You can get lymphadenopathy, and ultimately these children will die. I think that's pretty much all I wanted to talk about here. It's really nothing else as far as the test goes. But the ones that you want to know for the test are the X-linked and then the ADA deficiency. Okay, so hopefully you now kind of know that this is a heterogeneous disorder. Severe combined immunodeficiency is not just one disease, but for the USMLE, if they ask you in the context of severe combined immunodeficiency, primarily they're talking about X-linked. So to start off your diagnostic battery, you want to get a CBC with a smear and a manual differential. You're going to do that anytime you have a child that you think has an infection. If you do this, you should see a decreased absolute lymphocyte count. But it could be normal, and a normal ALC does not rule out severe combined immunodeficiency. I'm getting tired of saying that already. But one of the things is if you see a child with immunodeficiency and a decreased absolute lymphocyte count, what's going to be one of the things you think of? You're going to think of leukemia. However, these children are a lot younger. So if you see a 3-year-old with a decreased ALC and infection, then definitely go ahead and think leukemia. However, we're typically not thinking leukemia in a 6-week-old. It could happen, but something that's primary immunodeficiency is more likely. Another thing you should do anytime you have a child with severe immunodeficiency who is very, very young, and by very young I mean like 1 or 2 months old, is get an HIV test. Granted, if you look at mom's labs that she got while she was pregnant, she probably got an HIV test. You can look at that, but no matter what, you should get an HIV test in an infant, a very young infant who's got severe immunodeficiency. A SED rate can be useful, but really all it will show you if it's elevated is that there's been chronic infection going on. A mitogen response testing, it tests the function of your T cells. And so if you get a mitogen response test, we're actually typically looking at testing with something called phytohemagglutinin, I believe it's called. You'll see that the response is absent. And then quantitative immunoglobulins, typically they're all going to be low. However, IgG may be falsely elevated. Another thing you can do is look at lymphocyte markers. Lymphocyte markers are just, and you can usually do this in your flow cytometry too, but lymphocyte markers are just looking for these cell factors, and what these factors are is they're indicative of the cells that you've got. So CD3, CD4, and CD8, you would expect to see that in the presence of T cells. CD19, you would expect to see that in B cells, and CD16 and 56 are the natural killer cells. So from there, you can go ahead and do flow cytometry. That should show you low T cells in the peripheral circulation. Note that you may have B cells in the circulation. Why do we have why do we have B cell immunodeficiency signs if we have B cells in the circulation? And the reason is because, remember, in order for B cells to function, you have to have proper T cell activity. And so you may have B cells, but they're not really doing what they should because you don't have class switching. So you'll see low T cells in the peripheral circulation, but your B cells may be normal. The natural killer cells, it really depends on the type of immunodeficiency you've got. So typically with the X-linked severe combined immunodeficiency, I keep wanting to say subacute. I think I'm thinking subacute combined degeneration with SCD. So severe combined immunodeficiency. With X-linked severe combined immunodeficiency, you will typically see an absence or very low natural killer cells. On the other hand, there are other SCIDs that you will see natural killer cells in. So, for instance, the REG1, REG2 mutations, you will see natural killer cells. The IL-7R alpha deficiency, you will see natural killer cells as well. So that really depends. But for the X-linked SCID, you're going to see present B cells, but you'll see low T cells and low natural killer cells. Remember back to the T cell disorders, in that lecture I talked about the TRex assay. And the TRex assay really tells you if you have T cell development going on. Now, for instance, in DeGeorge syndrome, we don't have T cell development because we don't have a thymus. In X-linked severe combined immunodeficiency, we don't have T cell development because we have a block early on in T cell development. So when you're going through all of that T cell maturation, you have introns in your DNA that you're splicing out, and those introns, as they're spliced out, will form little circles. So you cut off the introns in the DNA, and that kind of goes off and does its own thing, and the 3' side and the 5' side just kind of naturally connect because, you know, it's like polarity, right? And when they form those little circles, that's what we know as these TRex, and you would expect to see abundant TRex in a child because they're forming lots of T cells. In a child who's got, for some reason or another, they're not developing T cells, you would expect to see decreased TRex. And in some states now, they are actually doing a TRex assay as part of the routine newborn screening. And then genetic testing for SCID X1, that is typically the gene that is mutated in X-linked severe combined immunodeficiency. So for management, these children are going to be put on the fast track for bone marrow transplant. We do transplant with an HLA identical donor, and we deplete the T cells because we don't want graft versus host syndrome. And what we're using is the progenitor cells, the stem cells, which then can go on to develop normal cells. Until then, you want to complement their immune system as much as you can. So you'll give them IVIG, which at least will kick in their humoral immune system. And so that would be 400 to 600 milligrams per kilogram every 3 to 4 weeks. However, we don't want them to go without the bone marrow transplant very long because the survival is much better if they get the bone marrow transplant before 14 weeks of age, so roughly 3.5 months old. Until the transplant, you're going to continue doing IVIG. You'll do consultation with clinical immunology, infectious disease, hematology, since they're going to be doing bone marrow transplant. You'll do antibiotics as needed for infections, and then you'll also do prophylaxis. So any child with a T cell immunodeficiency or a combined immunodeficiency is going to be receiving pneumocystis jirovecii prophylaxis, just like in an AIDS patient. And we will do that with Bactrim, trimethoprim, sulfamethoxazole. You can do prophylaxis for candidiasis, and that you can do with nystatin. For viral infections, typically we only give prophylaxis if we have reason to believe they've been exposed to varicella zoster virus. That tends to be the most problematic virus. that they can be routinely exposed to. And so in the case where you think they may have been exposed to zoster, so for instance, if 3-4-year-old brother or sister comes home with chickenpox and is around baby, you're going to be putting the baby on acyclovir and then varicella zoster immunoglobulin. Remember, no live vaccines. They don't have T cells, so we do not want to give them live vaccines, especially polio. You can give the child polio, cripple them for life that way. And then if you do give blood products, if that does become necessary, they need to be irradiated. So you're killing off any existing T cells so that you don't get graft-versus-host syndrome. Prognosis is guarded. However, if they are treated early, the prognosis is actually pretty good. Another thing here that you can do, a lot of these kids have eczema. These babies can have eczema. You can give cyclosporine for that, or you can just do topical corticosteroids. But that really is optional. That'll be at the call of the infectious disease specialist or of the immunologist. Graft versus host disease, I just want to spend 1 minute talking about that. So when baby is born, occasionally they can have this sort of allergic-like rash, just very, very mild. And that's often due to the fact that there are some T cells from mom. Not a lot, but some. Now, on the other hand, if you do a transfusion and you didn't irradiate it, or we would hope you would never do that, but let's say you did a transfusion and you didn't know that this child had a severe combined immunodeficiency, and you just went ahead and did a transfusion, you can wind up with graft versus host disease. And all that is where you've got T cells that you're putting in from somebody else into the person, into the receiver. And those T cells are not clonally deleted to not react against baby, in this case, baby's self-antigens. And so those T cells that are in the blood products are going to attack the baby's tissue. And that's really how graft versus host disease works anyway, for anybody. So what you can get from that is a necrotizing erythroderma, which is just a skin, not an infection, but an immune reaction against the skin. You can get biliary epithelial dysfunction, and then you can get sort of an abrasion of the gut mucosa. Okay, so this child, his name is David Vetter. He was back in the 1970s and early 1980s. He lived to be about 14 years old, but he had X-linked severe combined immunodeficiency. And you may have seen a movie that was made based off of him called The Boy in the Bubble. Back then, we really didn't have the armamentarium of antibiotics that we have now. We also didn't have IVIG developed to the level of technology we have it now. So this was their way of really treating him. It's unfortunate. But he wound up surviving. I think he was 13 or 14 when he died. But yes, this is a real-life case of SCID. Okay, so adenosine deaminase deficiency. We already kind of talked about this a little bit. This is the second most common severe combined immunodeficiency, second only to the X-linked form. And it really looks just like X-linked severe combined immunodeficiency, just with a couple exceptions. So first of all, there are some bone manifestations. That's kind of random, isn't it? And yes, it is. Why does that happen? Probably because adenosine deaminase is expressed in other tissues, whereas the gene for that we see in X-linked is really just specific to the blood. It's primarily coding for those IL receptors. So these bone manifestations are primarily costochondral abnormalities, and the most prominent finding that you're going to see is this rachitic-like rosary. And I say rachitic-like because it's not a rachitic rosary. Remember, rachitic rosaries, they come from kids with rickets. But it'll look just like that because you have this strange issue going on at the costochondral junction on your ribs. You can also see abnormalities in the apophyses of the iliac bones as well as the vertebral bodies. If you get an x-ray, you look at the vertebral bodies, it'll kind of look like this bone-in-bone appearance. Another thing is that if you get a lymphocyte count, whereas with X-linked SCID, it will be low, it'll be below 2,000, but it won't be super low. With adenosine deaminase deficiency, the lymphopenia is going to be profound. It'll be less than 500 per cubic millimeter, so very, very low. The management is virtually identical to X-linked SCID, other than, so our ultimate treatment is going to be bone marrow transplant with HLA identical donor cells. However, if we can't do that right away, there are a couple other routes we can go. So if bone marrow therapy is, bone marrow transplant is just not feasible at all, you can do gene therapy. So that is an option that we have with ADA deficiency that we don't have with the X-linked version. If that's not possible, so if you can't do bone marrow therapy or gene therapy, you can give pegasylated ADA. So basically you're just replacing the enzyme that's not there. That's not going to be a cure. Ultimately, you'll continue giving this and their response to it will be less and less. But at least while they're waiting for bone marrow transplant, this can enhance their immune system until then so they don't get something really bad and die from it. Okay, that having been said, if you are going to do a bone marrow transplant or if you're going to do gene therapy, you're going to need to stop the pegasylated ADA in advance, because giving the pegasylated ADA, what happens is that it does allow you to have a graft versus host reaction to either of these treatments. So you will need to stop that in advance, and we will never give this if we know that there's going to be impending bone marrow therapy like next week, or if you're going to do gene therapy in the near future. Post-transplant, the B cell number and function will recover, and that stands in contrast to X-linked SCID. So with X-linked SCID, you will continue to have B cells, however, you will not have proper B cell function ever at all in the future, even though you'll have B cells. And the reason is because even though you're giving a transplant, you'll have T cells, then you still have those receptors that are still mutated, and those are on the B cells too, and so you will not recover proper B cell function. Now, on the other hand, with ADA deficiency, you will recover your B cell function. You should have proper B cell function and proper B cell number, because this is only a problem of B cell production. So once you get B cells and you have proper ADA, there's really no problem there. So this is not a problem of receptors. This is a problem of a specific enzyme. That once we replace the bone marrow, once we do the transplant, there's really nothing problematic anymore. You have the enzyme. This is not a problem with receptors where you're going to continue to have receptor issues. I don't know if I'm making that make sense, but let me just put it this way: if you have a receptor problem as the basis for your severe combined immunodeficiency, you're not going to recover that just by doing a transplant. So B cell and natural killer cell function will continue to be abnormal. Whereas with this is a special case. This is an enzyme. This is not a receptor deficiency. So your B cells and natural killer cells will recover. And so this is kind of what separates it out. Okay. If I didn't make that make sense, please ask me a question below. I'm trying to explain this as best I can, but some things are a little bit harder to explain without a picture, at least. I should have put a picture on here or something. Okay, whatever. Vignette number 2. So here we have a 3-month-old boy presenting to your clinic with his parents who complain of maroon-colored stools for the past 24 hours. Baby was born term to a G1P1 mother, uncomplicated via spontaneous vaginal delivery. Birth weight was 6 pounds 14 ounces at the 32nd percentile. Parents note that there was some extended bleeding from the umbilical stump and circumcision site, but they did not bring him in because ultimately it stopped. Since then, medical history is significant for 2 episodes of acute otitis media which responded to antibiotic therapy. Baby is vitally stable, weighing 13 pounds 4 ounces. You note mild crusty erythematous rash along the back and the legs, along with what appears to be purpura. Physical exam is otherwise normal. Labs reveal normal electrolytes, but a platelet count of 18,000 per microliter. So, what is the most likely diagnosis here? You can go ahead and pause it. You should be able to figure it out just based on this information alone, because I did give you the labs. Alright, so if you look at this presentation, you will note that for the most part you have a normal baby. However, presently there are some things wrong. So what's not wrong? What's not wrong is that this baby is not failing to thrive. So baby is continuing to track in the 30 to 32nd percentile. There's been a history of some infections, but really it's just 2 episodes of acute otitis media. That alone, you're not going to make a big deal of that. So babies can get ear infections, and this baby just happened to have 2 ear infections. So you're not going to make anything of that by itself. However, now here you have some other things. So you have a history of prolonged bleeding. That in and of itself might not be anything, but here we're trying to connect it to some things. So extended bleeding from the umbilical stump and the circumcision site. When you have a prolonged bleeding time, what does that tell you? That tells you have a platelet issue. Either a qualitative or a quantitative platelet defect. What do we also see here? Well, there's some bleeding going on elsewhere, namely in the GI tract. There's maroon-colored stools, so we have GI bleeding. So now we've got this baby with a history of bleeding and now bleeding going on now in the GI tract. That's going to prompt you to get a CBC just right there, because we're thinking of something wrong with the platelets. Either the platelet count is normal and it may be a qualitative defect, or the platelet count is low and hence you have a quantitative defect. You also see some other things here in the physical exam. So this mild crusty erythematous rash along the back and legs, that's eczema. And then you also see purpura, and that's probably consequential to the low platelet counts. So if you combine the fact that you have low platelets and purpura as a result of that, you also have eczema, and you have a history of infections, as we see in acute otitis media. That makes up the triad of wiskott-aldrich syndrome. And so we have low GI bleed in association with thrombocytopenia as well as eczema, and that points you towards wiskott-aldrich syndrome. You would need to do genetic analysis to know for sure, but I would bet the farm that this is wiskott-aldrich syndrome, and I wrote this vignette, so I already know. Okay, so wiskott-aldrich syndrome is an X-linked recessive disorder, and that's another thing. This was a boy. If this was a little girl, you would really be thinking of something else. This is X-linked recessive disorder involving what is known as the WASP gene, and the WASP gene is responsible for creating a protein called WASP, wiskott-aldrich syndrome protein. What do you think we knew about first? Wiskott-aldrich syndrome or wiskott-aldrich syndrome protein? We knew about the syndrome first. This is a relatively recent discovery. And WASP is a protein that is responsible for actin polymerization. And when WASP is mutated, it either doesn't work, and so you don't have actin polymerization, you get apoptosis from that, or the mutation results in a constitutively active WASP protein. And if you have that, then you have disorganization of actin, and that's going to result in apoptosis too. So, WASP as a protein is really only expressed in the blood cells. It's only expressed in the blood cells in the myeloid and the lymphoid precursors, and I mean, it'll be expressed downstream too, but it's really only expressed in the blood. So it's not expressed anywhere else, and for that purpose, we only see blood issues. So we can see issues with the T cells, which is going to lead to immunodeficiency. We can see issues with the platelets, the myeloid line, which is going to lead to your thrombocytopenia. And so it's really only issues with your red blood cells, theoretically, your platelets, and your white blood cells. So the clinical triad here is cell-mediated or humoral immunodeficiency, thrombocytopenia, and eczema. Okay, so this is eczema in a baby, just kind of a reddish rash. If you were to feel it, it would be kind of scaly feeling, crusty. So how do we go about diagnosing this? Well, anytime you have a child with either an infection or bleeding, you're going to have a CBC. And if you get a CBC, you'll see thrombocytopenia. And in particular here, if you get a smear, which you always should get if you're getting a CBC, unless it's just your routine CBC that you're getting to track a patient on a day-to-day basis, but if you're getting a first CBC on a patient, you should always get it with a smear because you never know what's going on morphologically, and you don't want to have to get another blood draw. So you start out with a CBC, get a smear, and you'll see thrombocytopenia with small platelets. And that small platelets is really key here, and that's going to cue you in towards wiskott-aldrich syndrome. I probably could have put that on the vignette, but I didn't. So you have a thrombocytopenia with small platelets. What if it was a thrombocytopenia with large platelets? You can get that too. That would be something like Bernard-Soulier syndrome, possibly, and that can give you bleeding too. However, here we have small platelets, and that points you more towards wiskott-aldrich syndrome. If you were to have thrombocytopenia with normal platelets, then it might be something else. It might be especially in the setting of infection, it might be leukemia. But this is small platelets, and that's characteristic of wiskott-aldrich. You want to get quantitative immunoglobulin since there's apparently an immunodeficiency here. In this case, IgM is going to be low, IgG will be variable, and IgA and IgE will be elevated. And I'm not exactly sure how we get this specific profile of immunoglobulins. What I have read, but don't quote me on this, is that there's hypercatabolism of IgM, and so that's what's causing the IgM to be low. Because typically we don't think of IgM as the one being affected, because IgM is the first immunoglobulin that's made. If there's going to be a problem, it's going to be downstream from that. So either they're all going to be low, or IgM will be normal and spared, but the other ones will be low. And what this is likely due to, like I said, what I've read is hypercatabolism of IgM. And so it's eating up your IgM, but the other ones are being a little bit more spared. Sed rate can be elevated, which indicates chronic infection. And if you get a mitogen response test for your T cells, it's going to be poor, indicating poor function of T cells. Flow cytometry. So you'll see low T cells, preserved B cells, and lymphopenia. So overall, your lymphocytes are going to be low. However, it's going to be the T cells that are primarily affected here. If there is hepatosplenomegaly present, you will want to get a CT because there is a possibility of malignancy here. And then genetic testing will help you nail down the diagnosis. So how else could this child have presented, or maybe if the child was a little older? So you have eczema. Anytime you have eczema in the setting of immunodeficiency, you really have a prime breeding ground for infection. And so you can get secondary infection from that eczema. You can get cellulitis, furuncles, abscesses. You're also, because you're at risk for I guess not at risk, but one of the bacteria that can affect you is Staph aureus. You can get impetigo from that. So all of those things you can see on the skin. As far as head, eyes, ears, nose, throat, you can have acute otitis media, you can have pharyngitis from strep, and you can also see thrush, which I don't know if we saw in this baby or not. Go back here. No thrush? No thrush. Okay. but you can get thrush because this is a combined immunodeficiency. They also are at risk for asthma, and that's just sort of the atopic, going along with the atopic symptoms. So eczema is by far the most common of the atopic symptoms, but they can also be at risk for asthma. You could also note rales or rhonchi, which would point you towards bronchitis or pneumonia. As far as the abdomen, you always want to palpate for hepatosplenomegaly because of the risk of malignancy. The most common malignancy that's going to develop in wiskott-aldrich syndrome is going to be non-Hodgkin's lymphoma. And remember that non-Hodgkin's lymphoma, if you see it in a child, probably more than likely going to be like a Burkitt's lymphoma. However, in wiskott-aldrich syndrome, actually the most common non-Hodgkin's lymphoma you're going to see is the large cell variant. And then, let's see, what else? There can be neurologic symptoms if there's a CNS lymphoma or meningitis, or a problem, a big complication you can get out of wiskott-aldrich syndrome is CNS bleeding. As a matter of fact, 1 in 50 patients with wiskott-aldrich syndrome, that will actually be how they present, is with intracranial bleeding. All right. So the management for wiskott-aldrich is going to be bone marrow transplantation, which is really the only curative therapy. Otherwise, you're going to give IVIG to establish a humoral immunity, 400 to 600 milligrams per kilogram per month. That's the standard dosage every month. And then supportive care, so eczema can be treated as it usually is, which is with moisturization and topical corticosteroids. Severe thrombocytopenia may respond to corticosteroids. If it's an ongoing problem and you really at loss of what to do if it's not responding to corticosteroids, they have severe thrombocytopenia, and you don't want to continue giving them transfusions, because remember, there is risk from that, from giving transfusions, graft versus host syndrome, then you can do a splenectomy. However, I will note here that if you do a splenectomy, even though it will virtually cure their thrombocytopenia, it actually increases mortality if you do a bone marrow transplantation after a splenectomy. Okay, I don't know why, but it does. Okay. Anemia, which would be subsequent to bleeding, may require iron supplementation or transfusion. Best way to get around that is to just make sure that you're treating their thrombocytopenia. Of course, no live vaccines. That goes for any of the severe combined immunodeficiencies or the combined immunodeficiencies. Avoid NSAIDs because of bleeding, and then surveillance for malignancy. Like I said, they are at risk for non-Hodgkin's lymphoma. Typically, their malignancy risk is roughly proportional to the severity of any autoimmune manifestations. So if they have really severe eczema, if they have autoimmune hemolytic anemia, if they have vasculitis, which is about 10% of them will have vasculitis, they're probably at higher risk for developing malignancy. All right, and then the median life expectancy, and I believe this is if they don't have bone marrow transplantation, is about 8 to 11 years. These patients are also going to be on antibiotic prophylaxis. So if they, it's optional to give them prophylaxis with penicillin. However, if they have a splenectomy, it's mandatory to give them prophylaxis with penicillin. You will also give them prophylaxis for pneumocystis jirovecii. Remember, that's just Bactrim. Okay. So our final vignette, a 3-year-old girl presents with her mother complaining of clumsiness. Mom says that she's always been clumsy, but lately she has noticed that her daughter has been tripping over her feet a lot more. There are no other complaints at this time. She was born term to a G3P3 mother with no birth complications. Motor, cognitive, and social milestones have all been attained as expected. Family history is non-contributory. You note in her chart that she has been seen, daughter, not mother, she's been seen 4 times in the past 2 years, twice for sinusitis and twice for pneumonia, which all cleared up with antibiotic therapy. On physical exam, you note a vitally stable girl and no apparent distress. Physical is notable for ocular telangiectasias as well as telangiectasias over the ear. Gait is grossly normal, though there is some waving and wobbling as she walks. Deep tendon reflexes are normal. Cranial nerves are intact 2 to 12. Strength and sensation are all normal. What do we have here? This is an easy diagnosis, at least on the test, because the disease is named after the symptoms. I mean, it can't get much easier than that. This is ataxia telangiectasia. So she's got ataxia, the clumsiness. She's got telangiectasias. She probably has ataxia telangiectasia. And another thing that points you towards ataxia telangiectasia is, even though it's not in the name, they do have immunodeficiency. Now, that immunodeficiency, even though this is a combined immunodeficiency, it is not as severe as the other two that we talked about. Typically, these patients will only get sinopulmonary infections, although they can get other infections. It's generally going to be restricted to the lungs and the sinuses. Now, that having been said, they're at risk for abnormal pathogens like pneumocystis, or I suppose they could also get Pseudomonas or Moraxella. So those are not things you would expect to see in other children. I mean, the infections can be severe, and the fact is, with these patients with ataxia telangiectasia, the most common cause of death for them is going to be lung infection. So this is not something to turn your back on by any means. But that being said, their infection profile is just going to be a lot less severe in general than children with the severe combined immune deficiency, for instance. Okay, so ataxia telangiectasia is an autosomal recessive condition that is caused by a mutation to the ATM gene, which sits on the long arm of chromosome 11. So this is autosomal recessive. Girls can get it too. And this gene codes for a protein called ATM, and that stands for ataxia telangiectasia mutated gene. Again, we knew about the disease before we knew about the protein. This is a high-weight protein, and it serves as a PI3 kinase, phosphatidylinositol 3 kinase, I believe that stands for, and that's involved in cell cycle regulation. So if this gene is mutated, you go into apoptosis, and it's going to screw up the development of your T cells. It also is responsible for DNA repair, and so for this reason, these patients are at increased risk for malignancy. They also are going to have degeneration of part of their central nervous system for this purpose. And that gives rise to the CNS symptoms, which characterize this disorder and really separate it from a lot of the other immunodeficiencies. So this disease is characterized by immunodeficiency, especially sinopulmonary infections, as well as oculocutaneous, meaning on the eyes and on the skin, telangiectasias, and progressive cerebellar ataxia. Okay, so immunodeficiency, telangiectasias, and ataxia. Ultimately, that cerebellar ataxia, that cerebellar degeneration, is going to descend into the spinal cord. It can lead to spinal muscle atrophy. It does lead to chorioathetosis. So this will sort of spread. The neurologic manifestations. So the onset is as early as infancy, though it may not be noticed until 5 years of age. So approximately 20% of these patients will be diagnosed before 1 year of age. About 65% are going to be diagnosed before 2 years of age, and that goes up to about 85% before 4 years of age. So it takes a while to diagnose this, and that speaks to the fact that the infections are really not as bad with ataxia telangiectasia as they are in severe combined immunodeficiency, where they're all going to be diagnosed by 2 or 3 months of age, or else they die. Ataxia will be the most salient neurologic sign early on. However, as they develop, and we expect their fine motor control to be a little bit more sophisticated, you will start to notice other things. So what you can notice is intention tremor. You may notice decreased deep tendon reflexes later on. Their plantar reflex will be flexion. Intention, I already said the intention tremor. Let's see, what else? Myoclonus, you can get myoclonus, hypotonia, You get chorioathetosis, which is an extrapyramidal symptom, but you can see how this sort of starts in the cerebellum and kind of spreads outward. You can also notice a masked facies, kind of similar to what you see in Parkinson's. And then if you do so notice that, I put this down here. So notice that in this patient, we had some waving and wobbling as she walked. And that can kind of look like, if you were to spin around and then start walking, how you kind of, can't walk straight. And it kind of looks like chorioathetosis too, but this is really just swaying. Now, when you think of that, you think of Romberg sign. So remember what Romberg sign is, where you're supposed to stand, balance, and then close your eyes. And if it's positive, you'll start to sway. And a lot of times, unseasoned physicians will document this as positive. But what you have to bear in mind is that these patients with ataxia telangiectasia will have that swaying motion regardless of whether their eyes are open or not. And Romberg sign means that you're going from being able to stand straight without swaying, and then when you close your eyes, you start swaying. That's a positive Romberg sign. If you're swaying to begin with, even when your eyes are open, and then you close your eyes and you're still swaying, that's not positive Romberg sign. So this is going to be a negative Romberg sign here. Okay, so the big thing that you're going to be differentiating this from is something called Friedreich's ataxia. Now, if you don't have real salient signs of immunodeficiency and you're not paying attention for those telangiectasias, this can look just like Friedreich's ataxia. As a matter of fact, the way we differentiate this from Friedreich's ataxia, at least clinically, is by the fact that patients with Friedreich's ataxia, while they have a cerebellar ataxia, they have decreased deep tendon reflexes, they don't have immunodeficiency, and they don't have telangiectasias normally. Okay, so if you know that the patient has an immunodeficiency, a history of immunodeficiency, then it's going to be much easier to differentiate it out, because that doesn't happen in Friedreich's ataxia. Now, there's other things that you can do to differentiate ataxia telangiectasia from Friedreich's ataxia, and that's going to be primarily on MRI. And I'll show you some pictures of that. Okay, so here is ataxia telangiectasia, although you cannot really notice it here because the flash is kind of screwing this up here. But if you look really closely at his eyes, look at that. So you might look at that and think, oh no, that's conjunctivitis. Remember, with conjunctivitis, you're going to have a lot more smaller arteries that are kind of engorged. And so when you see these engorged arteries, that's not what they are, they're telangiectasias. But if this were to be conjunctivitis, you'd see these arteries on a pink background rather than on a white background. So that's how you really distinguish it from conjunctivitis. And also, if you ask mom will tell you, no, kids always had these. All right, so those are ocular telangiectasias. And you can have these normally. There are some people who have ocular telangiectasias, and that's it. But it should cue you off in a setting of immunodeficiency or in the setting of ataxia. So here you see it again. Notice that the lids are a little weak here. I'm not sure if I'd call this ptosis. It would be difficult to, without actually examining the child. But notice weak lids. That is at least suggestive of possibly being ptosis, and that is a possibility with ataxia telangiectasia. They can get ptosis. So extraocular weakness is they do have progressive oculomotor signs. And remember what innervates. So here's the telangiectasia on the ear. So where do they get these telangiectasias? As we see, they get them on the bulbar conjunctiva. They also can get them on the upper part of the ears, as we see here. They can also get and this is a little bit more rare, but they can get a butterfly distribution of telangiectasias on the face. And they also get them on the flexor aspects of their extremities. Okay, so for diagnosis, Initially, you'll start out with CBC and smear, and that's primarily because you're thinking possible immunodeficiency, at least with how they, depending on how they present, really. And that will show a modest decrease, possibly in ALC, absolute lymphocyte count. You can get quantitative immunoglobulins. IgM will be normal or high, IgG will be variable, IgA and IgE will be low. All that's really telling you is that you don't have really good class switching going on. What else might you see? Mitogen response testing will be poor. That's just indicating that this is a T cell problem primarily. And then if you get an MRI, which you always should get an MRI if you've got a kid that's unable to walk properly without stumbling on themselves, you would note things such as cerebellar degeneration, widened cerebellar sulci, and enlargement of the fourth ventricle. Now, if you ever suspect ataxia telangiectasia, you will always get an MRI and not a CT. Granted, MRI is a better test here anyway because we want to look at the fine geography of the brain, but there's a reason we avoid getting CTs, and for that matter, X-rays. And we always try to avoid it in kids, but specifically in ataxia telangiectasia. Remember what that protein is, ATM, what it does. It's involved in cell cycle regulation and DNA repair. If you already have a gene that's mutated, that's supposed to be responsible for DNA repair, which is another way of saying it's preventing you from getting cancer. Do you think we want to expose them to ionizing radiation? No, we do not. These children are already at 100 times risk for cancer. So we avoid X-ray and certainly we avoid CT. MRI does not expose them to radiation, so we can do that. And then genetic testing is going to be your most definitive means of diagnosing this. Some other things that you might see later on in ataxia telangiectasia is, and this is just goes to show you sort of the progression of this. Ultimately, by early adolescence, they're going to require a wheelchair. So you see how this progresses. They start out, they're able to walk kind of normally, maybe a little stumbly, but all kids kind of walk stumbly when they first start walking. And by the time they hit 5 years old, they're really having difficulty staying up on their feet. By the time they hit 10, 11 years old, they're going to require a wheelchair. So it gets worse and worse and worse. It really becomes evident after about 5 years old. They also get this strange, I'm not sure what causes this, but this dystonic positioning of their fingers, and that's how they hold their fingers. It's not due to any, I don't think it's due to any neuromuscular issue, but it's just how they hold their fingers, and I think it's like more of a movement-related problem, but I'm not sure there. But this dystonic positioning of fingers, I didn't put a picture of that on here, but you can look it up on like Google or whatever. Okay, so here is an MRI, ataxia telangiectasia. What you're noticing here is, so you might not think of, this is a small cerebellum, but what should tip you off is the fact that generally the cerebellum is going to go all the way down, at least close, within a few millimeters of these two bones down here, which make up your foramen magnum. The foramen magnum, remember, is just that hole in the skull where your midbrain and spinal cord go out. So your cerebellum really should go all the way down here. Now, if you were to look at this in a very, very young baby, for instance, what's one thing that would be on your differential for a small cerebellum and widened fourth ventricle? Dandy Walker malformation. So that's one thing you might think of, but we see here that we would not see in Dandy Walker malformation. We see here are these very deep sulci in the cerebellum, and that is indicative of atrophy of the cerebellum. Okay, so note you've got a large fourth ventricle and you have atrophied cerebellum. Now, another thing you can do, and I didn't put any pictures of this, but since you're getting an MRI anyway, another thing that can help you with diagnosing ataxia telangiectasia is looking at the adenoidal tissue in the nasopharynx. It should be decreased or absent. And that's something that if you are looking for ataxia telangiectasia, getting an MRI looks like that in the setting. You've got immunodeficiency, you've got clumsiness. Put what you think your diagnosis is, in this just for practical purposes, put what you think your diagnosis is when you send it to the radiologist, because your radiologist will know, okay, well, maybe I should look at these other things that might help my pediatrician. And even though you might not think that that there's other things to look at, your radiologist will know, and your radiologist can tell you, yes, not only the cerebellum has atrophied, but there is also absent adenoidal tissue, and so your diagnosis is probably correct. So just as a practical matter, always fill your radiologist in. I've said this a million times in my lectures, but always fill your radiologist in on what you think is going on. And it makes their job easier too. Okay, so here you see another really, really tiny cerebellum. Everything else looks pretty normal, but tiny cerebellum. Other things you can see sometimes in brain tissue. It's not unusual to see a little bit of white matter degeneration, certainly not, it's not going to be diffuse. You can also see some microhemorrhages, and that's telangiectasias in the brain. Okay, so here you see a almost total degeneration of the cerebellar vermix. And then also notice, this is a T2 weight, but notice you can see the white penetrating way deep into the cerebellum, and that's just showing the deepened sulci of the cerebellum. And then note the enlarged fourth ventricles here. So again, here you see it, same patient, 5 years old, and 13 years old. So notice how much more of that contrast is getting in to the cerebellum. All that means is that the cerebellum is atrophied. So this is relatively normal here. You see a little bit of atrophy, a little bit of penetration here, but this is obviously very atrophied. But note that the cerebrum is normal. It looks like, there's more stuff here, but it's just because it's a different cut. So the management for ataxia telangiectasia. We want to promptly manage their infections. That does improve life expectancy in these patients. So we will give them IVIG to establish a humoral immunity every month. Antibiotic treatment as necessary, and then pulmonary follow-up. And this is interesting. We manage these patients, as far as a pulmonary perspective, very similar to cystic fibrosis patients. So let's think of it. What do we have in ataxia telangiectasia that's similar to cystic fibrosis? Well, they're really not similar, but they kind of do the same thing. So with ataxia telangiectasia, you're at risk for respiratory muscle weakness. With cystic fibrosis, you have thickened respiratory secretions. Both of those are going to make it difficult to cough things up. Okay, so what does that mean? If it's difficult to cough things up, mucus sticks around for a long time, and you get proliferation of bacteria. Now you add on to that the patients with ataxia telangiectasia are immunodeficient. What are they at risk for? Namely, they're at risk for Pseudomonas. And so this is something that is common both to the CF and the AT patients. They're at risk for Pseudomonas pneumonia. And so what are we doing with them? We're going to do airway clearance therapies. So we might not need to pound on them, but we do need to make sure that they're coughing sufficiently. So we can do, whereas with the with cystic fibrosis, we're pounding on them to get that mucus loosened up. With patients with AT, we want to focus on strengthening their respiratory muscles so that they're coughing appropriately. But other than that, it's going to be pretty similar. So we're going to get pulmonary function tests. We're going to get regular sputum cultures. Anytime they develop a fever or a change in their sputum, we want to get a culture to look for Pseudomonas because The main problem for these patients, what ultimately will be the cause of death for most of them, will be bronchopulmonary infections. And you can bet that just like in cystic fibrosis, having Pseudomonas is a negative prognosticator. The one difference, though, compared to how we manage CF patients and how we manage AT patients, is that with a CF patient, we're often getting chest radiography. We'll do that frequently. With AT patients, no, 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 no. You're going to be avoiding that as much as possible. All right, neurologic manifestations, mostly just managing that symptomatically. There's really nothing we can do, unfortunately, for the neurologic manifestations. Physical therapy can help, but it's really just managing it symptomatically. Regular surveillance for malignancy. So these patients are at risk for a whole host of cancers, but the ones that we're thinking of are non-Hodgkin's lymphoma, namely mantle cell lymphoma, and then T-cell prolymphocytic leukemia. It happens to be that mutations in that region of the ATM protein or gene. Also, there are, let me put it in a different way. If you have a mutation to the ATM gene, it can affect genes that can cause those cancers. In addition to that, another gene that is regulated by ATM is the BRCA gene. Remember the BRCA gene, BRCA? That's if there's problems with that gene, which even though that gene may be normal in and of itself, because it's regulated by ATM, if ATM is abnormal, their expression of BRCA can be abnormal, and that can put them at risk for breast cancer. Now, that's not so much a problem in these children, because typically their life expectancy is only about 20 years. They generally don't get to the point where they'll get breast cancer. However, we know, because this is an autosomal recessive disease, that mom is a carrier. And so because mom is a carrier, she actually also has a higher risk for breast cancer just by virtue of being a carrier. So mom needs to be wary of breast cancer, and she needs to be making sure she's getting her mammography. And I read up on it. I do not believe, based on what I read, the recommendations I saw, just because you're a carrier doesn't mean that you're going to have that hypersensitivity to x-rays. So I believe with the hypersensitivity to x-rays, that's just the patients that have ataxia telangiectasia. So mom can still go in and get mammographies and not worry about it. As a matter of fact, she should, because she's at risk with the BRCA issues. Okay. Let's see, what else okay, so if they do develop malignancy, I think I already said this, but most likely going to be non-Hodgkin's lymphoma or acute lymphocytic leukemia. Right, and then consultation with medical genetics, neurology, pediatrics, immunology, infectious disease, and physical therapy. So a multidisciplinary approach. Oh, yes, now I remember the other thing I wanted to tell you about malignancy. So these children have virtually no discernible lymph nodes. So if you are ever doing an exam on a child and you even can feel lymph nodes, you're sending them in to get worked up for lymphoma. Average life expectancy is approximately 20 years of age. The most common cause of death are bronchopulmonary infection and malignancy. So what I want you to do after this, because I didn't make a slide for this, a special slide for this, but I want you to make a list of all the things that you see in telangiectasia, or ataxia telangiectasia, and all the things you see in Friedreich's ataxia, and compare and contrast, because I guarantee you, both of those disorders, they come up often on the USMLE, and you want to be able to know the difference. Namely, you get immunodeficiency in AT, you don't in Friedreich's ataxia, but what happens if you have a patient who has not had frequent infections or doesn't report frequent infections? How do you know the difference then between ataxia, telangiectasia, and Friedreich's ataxia? Another way you can go about it is that with AT, you'll have a negative Romberg sign. Friedreich's ataxia, you have a positive Romberg sign. But there are some major differences on the MRI. and I'm going to leave you to look that up yourself. If you want to know, you can private message me, but you should probably look that up yourself. I'm giving you guys homework now. This is great. So you should love me. Anyway, if you have any questions, go ahead and let me know. For the most part, these are all rare syndromes. Wiskott-Aldrich is only about 1 in a quarter million. Ataxia telangiectasia, a little bit more common, about 1 in 10 to 100,000, depending on the population. And the most common of all of these that we talked about was the X-linked severe combined immunodeficiency. That's actually going to be about, I believe, 1 in 6,000 male births. So I'll see you in the next section.